couple of things before.
Take it away.
Daniel, you ready?
Yeah, I just put the recording on, so.
We can't hear you very well again. You're doing your usual muted thing.
Is it better now?
It is bad.
Oh, boy. No wonder you weren't responding to my comments, David. Couldn't hear me. All right.
No, I couldn't. It was like a muffled Scottish student at the back of the class.
Anyway, welcome everybody. Great to see so many folks. I'm just going to share an agenda for today. And as Christine said, we are going to end it actually 5 minutes to 5. Our goal is to end 5 minutes early. There's a lot of competing things that are happening after that. So we're gonna move swiftly along here for the first upfront part, and then turn most of our focus to today's presentation by Hans and David and Michael, who are here from the CHRA Association. Somebody put themselves on mute. Thank you. The association affiliated with him. So we're going to spend most of the time on that. And so with that, we usually do introductions, but we have so many people here, I'm afraid we would use up all the time. So if you're new to the call, please just say something in the chat. Where you're from. If you haven't been here in a while, just introduce yourself, or if you just feel like you want to say something in the chat anyways, by all means, in terms of where you're from. It's really exciting to see everybody here. So with that, Brian, you have, we just did a couple of quick updates. One from Brian on the director.
Certainly. We had the HL7 Human and Social Services Working Group has had a project to develop a human services directory implementation guide, specifically how to map between open referrals, human services data specification, HSDS, and FHIR. That implementation guide had been built out enough for us to be able to start doing some testing on it. We had an ad hoc connect-a-thon, a virtual test event last week, and on the 25th, and we got a good turnout. We got, I think, 3 different implementations of the directory service side. We got 3 different implementations of clients calling the directory service and testing out. We found some problems, as one does in testing, but really the specification stood up pretty well. So this past week, the Human and Social Services Working Group voted to submit a notice of intent to ballot in January of 2023 of the FHIR IG for Human Services Resource and Provider Directories, I think is its formal name now. So something to look forward to. And that's it from me on that topic.
Thanks, Brian. Chris, you want to go with introducing Chuck?
Yeah, so let me just ask Chuck Curran to talk a little bit about the ADPPA. He's already put in the chat a link to a recent health affairs piece that he and some colleagues authored. And we wanted to have him have a minute or two to discuss that and determine whether there are other folks who are interested in working collectively together on helping to get this piece of potential legislation forward.
Thanks, Christine. Knowing the interest of this group in legal developments affecting consent for different public services uses, I've shared an article about a coming wave of, or a happening wave of federal and state privacy laws, most important of which is a federal proposal that may or may not happen, but it's certainly the closest it's come in the last 15 years to actual comprehensive federal privacy law. It's called the American Data Privacy and Protection Act. The good news is that it leaves intact data flows from the health system, from clinical health to that are governed by HIPAA. The bad news is that for other non-governmental entities, including, most importantly, nonprofits, there could be robust new affirmative express consent requirements for collecting or sharing health data, race or ethnicity information, or any information related to a minor under 18, if that data isn't being collected for anything other than an express governmental purpose. Really, in a nutshell, this is a law that's been designed to constrain the commercial sector, but the question is, have they inadvertently captured some of the activities outside of government that touch on health or other potentially sensitive information?
Leading up to the conversation with Paul that we had a couple months ago, we actually had
Somebody's on speaker.
what that funding to look
So,
like.
Hang on a second, let me,
Discussing it with Jake. So we have that vision of, what's it going to take in terms of funding Trump.
okay. Now, let me. Okay.
I think
are you
you
back?
have, yeah, all right, now you unmuted him. You
Yeah.
can
Yeah.
mute yourself, everyone, when needed.
Yeah, and so I've shared a link to the article sort of teeing up the basics and my contact if you're interested in diving a little deeper and helping to test that we haven't inadvertently got a commercial law that interferes with a lot of the good projects that Project UNIFY is thinking about. So I invite you to get in touch and I can share more information on the ADPPA.
Great. And you might want to, just because when people join after you've put something in the chat, they can't see it. So do you want to put that link in one more time, Chuck? That'd be really helpful. There we go. Perfect. Thanks. All right. Daniel, you also had an agenda item about Sync for Social Needs. Did you want to talk about that?
Yeah, just one quick thing. This is really more about who knows what's going on. I've been seeing, and others have been seeing this, the effort of Sync for Social Needs happening, which is great. It's getting, federal different attention at different levels. Just curious about it, and if people are involved with it. It seems like potentially, sort of the application of the work we're doing here, but also duplication of efforts and then missing opportunities. So I wanted to just raise it and say, is anybody involved with Sync for Health and you know what's going on? Now would be a good time to say a few words. All right, it's a secret then, eh?
Apparently.
I reached out through the grapevine, and I believe that Dan Vreeman from HL7 is the contact person for Sync for Social Needs.
Oh, great.
I've reached out to him via email on behalf of the NIC and UNIFY and Direct Trust and ICFIS and HL7 HHS, because in all of these different places, I have had people coming to me saying, what's with this Sync for Social Needs thing? What do you know? So I have not heard back from Dan yet, but I only reached out yesterday, and you know how it is when you try to get a hold of somebody who's busy.
Okay.
I did reach out to Dan, or I just reached out to that email address that they posted to, if you want to join. I sent that on the 27th of October and just heard back today from Dan Bremen, and he CC'd Brett at Wave One Associates, Josh Mandel from Microsoft, and Catherine Flatley from Care Journey. And this was a response. This is in the context of, our company joining. Some of the companies in our domain are already participants. So I'm wondering, how do we miss that boat and how do we get on the boat? And this is the response. The idea is that participants, this is from Dan, agree to work towards using a fiber-based and link-coded approach to capturing, scoring, and making available social needs assessments. So that sounds a lot like Gravity to me. Anyway, our initial focus, led by Brett, Josh, and Catherine CC'd, is on environmental scan interviews to understanding the current state of technical approaches to sharing social needs screening data among participants. Given blah, blah, blah. So I guess we're going to do an interview with them. So I think they're trying to figure out what our approach is. Now, we're a service organization, or we have service organizations as customers. And, first phase of Gravity and all this is not for getting the data from the places that normally collect that data. It's from collecting at a clinical area. So I don't really want to get involved in that because we're not clinical, but what would be cool is when the referral is made outbound, to help somebody with, say, housing in our case, we could receive that referral, serve it, close the loop, and do that last part. But I don't know. We'll see what they think about that. Maybe they'll think it's out of scope, or later phase. But anyway, that's just what I.
Great, thanks. Well, we'll keep looking around and see what's going on there, because it does seem like there's a lot of overlaps, and let's not lose the opportunity to add to the momentum if possible. But just for that point, I'm going to take 2 more minutes and then we'll turn over there. One thing is, and I was going to actually put this slide up here for the introduction, but I'll just say a word here now, and then I'll hand it back to Christine. So in the scan that we did last year, we looked at a lot of the promising consent-related practices. So as Sync or others are doing it, there's a body of knowledge here, and this can be added to. We created a tab where you can actually add resources. So if, as you think about or come across other organizations doing this work, let's make sure we, just don't duplicate the work. It was too much to do it again. And just as another bit of background, so the electronic health record systems here was one of the areas that we were looking at when we were doing the scan. That's where we got connected to HIMSS and the association, which is the origins of this call today, because we had the conversation, we put something in, sort of a kind of a boilerplate into the scan here, and then have had a couple of subsequent conversations. So I just wanted to show that for both those purposes. And then the last final thing, thanks for renewed members. But the last thing, I just wanted to call this out one more time. Brian, can I ask you to just also say a word here, since you were so vociferous with your support for it in the LinkedIn.
Yeah, for the last year or so, the Administration for Community Living, the folks that oversee aging and disabled communities on behalf of HHS, has been running a social care referrals challenge, multiple phases of the challenge, and that what we've ended up, we ended up with 3 different consortium, basically, receiving the grand prize, first place. One of those was the Firefly team, which was May, June, and Open City Labs. Now, my emphasis here is that this is May, June, and Open City Labs, who have been longtime members of Project UNIFY. We've done multiple different proof of concepts here in the UNIFY environment, trying to address the specific needs of and requirements from business partners that are participating in UNIFY, as well as other technical partners. And so Firefly won on the strength of all of the work that we have all done together within UNIFY, and understanding and figuring out what needs to be done, and then being able to demonstrate it. So I want to give kudos to May, June, and of course Open City Labs, for whom I'm a CTO, but also kudos to everybody that has participated in Project UNIFY, because this is one of those takes a village moments.
Yes.
By the way, OCL and Firefly also won the bonus round for mapping taxonomies. So it was quite the coup. So thank you to our May, June partners, and thank you to Matt, and of course me, Open City Labs.
I wanted to just say a word, make sure that Dr. McCoy didn't escape without some credit.
Oh, my apologies. Yes.
So when the challenge was going on and we were at the beginning stages of Open City Labs being brought on as the referral management platform for the New Jersey Integrated Care for Kids program, she said, you should sync up with May, June and join in on this challenge there, and so we did, because we were already integrating for the NJ Inc. contract anyways. And then we demonstrated at the CMS Connectathon and brought in Sunbelt. Am I getting their name wrong, Brian?
Gold Belt.
Gold Belt, thank you. who is the OPRE of ACF and brought in, and we did a CMS Connect-a-thon with them and demoed those standards. And yeah.
And Dr. McCoy was not just playing matchmaker here. It was her vision for New Jersey Inc. that helped inform a lot of the requirements that we OCL have been building towards.
Which is all not just about this one demonstration and serving this project, but truly being able to interoperate across systems, being able to reach people in their system of record, whether it's an EMR or, we'll integrate with anybody, and doing that at low cost. So I want to make, she got a plug.
I think we will take that as a great lead-in to our speakers, Matt. Thank you very much for those kind words, gentlemen. And speaking of integrating into EMRs, I wanted to turn things over to our speakers today, Hans, David, and Michael, who are joining us representing the work groups for the Electronic Health Record Association around interoperability and privacy and security. So hitting right into the heart of the NIC, and also our current focus on consent in terms of the privacy and security. So I think we've got some, interesting discussion to hear about this from the perspective of the folks that are in the heart of this big push to integrate social determinants of health into medical care, and the forces that are changing for them. I did put into the chat a link that I got earlier today about an announcement of a ONC pilot that sounded like it's being driven by the new requirement that hospitals screen for social determinants of health. And of course, they've got to be able to report on that. And that, of course, is a big challenge for the electronic health records, as either the place where that screening gets documented or where it gets pulled into from other systems. So, that's certainly a piece of it. I have in my recent explorations of some of the leading electronic health records have been seeing a lot of sort of new tools and interesting things being integrated into them. Little beautiful color wheels demonstrating to the medical team, what's going on with the patient in terms of social issues, et cetera, and integrations into referral platforms, et cetera. And all of this sets up a lot of challenges around interoperability and as well as privacy and security. So with that, I'm gonna turn things over. I think, Hans, are you kicking things off for us?
Yes, I will, and I'll do a couple of introductions. And thank you, Christine, for that setup. In that context, we're going to probably focus more on the privacy consent part, less on the specific examples around SDOH, whether it's SDOH or other data. There are similar considerations around that. So if I may, I can share my screen and get some slides up, and I will share them right after, so that if it's correct and Teams is working with me today, you should start to see a screen that says HIMSS EHR Association.
Yep, got it.
All right, it actually worked. Cool. So we have today 3 representatives from EHRA on the call, and we'll do a quick introduction and then jump into an introduction of EHRA, and then dive into privacy and consent considerations on some of the discussions that are happening within the EHRA. So first, myself is I'm currently the chair of the EHRA, and we'll learn a little bit more what that's all about. So I won't explain that yet. And that's during the time that I'm interacting with that team, daytime or nighttime, other time, I'm not sure, is Oracle Cerner, and that's from the Cerner path into Oracle. Prior to that, some Siemens, some Shared Medical that might be familiar names, and active in a variety of different industry settings. And with us today is also Dave Bucciferro. And if you want to introduce yourself for a moment. Oh, I caught him in the mute button search. You're still on mute.
How about now?
Yeah.
Finally. All right. My name's David Bucciferro. I work by day at the Foothold Technology and Radical Health. We're primarily a behavioral health social service type software. I came to that field after 35 years of working at New York State Office of Mental Health, where I did a lot of work on social determinants and employment and rehabilitation and things like that. I am the current vice chair of the EHRA. I also am the co-chair of our opioid task force. I also sit on the patient safety group, and I'm the current chair of membership group. So involved a lot with the HRA as well. Michael?
Hey folks, this is Michael Saito. I work at Epic in my day job, where I focus on regulations really that run the gamut of health IT focus. So everything from information blocking and interoperability and privacy rules, all the way through to No Surprises Act and price transparency regulations. So I'm involved in the EHRA as their privacy and security work group chair, but like David and Hans, I participate in a number of different work groups that the EHRA has.
All right, thank you. Going to look a little bit at EHRA to level set a little bit more. Not everybody may be familiar with what the EHRA is about, but it's a group of vendors that at one point in the process will compete with each other. But within the EHRA, we're working very strongly together to advance in a number of different areas the state of the use of HIT. EHR is particular around in the healthcare environment. So improving the quality and efficiency of care is really at the forefront of all of us and with our clients. That's what we're focusing on, and that we want to ensure with everybody that we can take best advantage of the capabilities, understand where to go, what opportunities are out there, and work together to enhance in general what's happening. Interoperability is very much a part of that. When we start to talk about privacy and consent, that's part of that, and many of the other topics that we're looking at, enabling a certain level of consistency while absolutely acknowledging that there are differences in approach and solutions. That's what we are really looking at as an organization. And it started back in 2004-ish, when a stronger focus was being put on regulations in the HIT space, the evolution of meaningful use, promoting interoperability, etc. That's where we are stemming from. So it's about 30 developers right now, all members of HIMSS. We are part of HIMSS from a structural perspective, but you will hear a specific focus from the EHRA on topics around that. It does represent pretty much the majority of EHR vendors and users, if you look at that, in an inpatient setting, outpatient setting, ambulatory, long-term care, behavioral health, variety of different settings, large and small health systems, individual practices. So there's a substantial amount of use by the systems by any of our members, and it's all about collaboration, not only among the members itself, but also with other stakeholders, other parties in the industry, and that's probably also important for this conversation today, where we are being reached out to find ways in which we can advance the use of HIT, quality of it, the connectivity of it, et cetera, et cetera. So always open to have those discussions and conversations. And then depending on what the situation is and the topics at hand, we will work more closely together with specific organizations on very particular topics, like recently with the HIMA and EHRA defining aspects of how to go about approaching electronic health information in information blocking. We're working with the ACP, AHA, others, AMA on topics around burden reduction in context of E&M encoding. And there's a number of different ones there. So this has certainly the potential, this area, of having some of those opportunities as well. These are the members. If you want to have a quick glance at it, you see them all there. We have the variety of working groups that tackle different areas. David and Michael already mentioned some of those. You will see here the variety that ranging from public policy, strongly focusing on the interactions with the agencies, federal agencies in particular, on the proposed rules they bring out, but also information blocking, where it is around how to provide guidance and insights and otherwise on how to tackle some of the information blocking provisions. So you'll see a variety of different perspectives that we focus on. And over time, that may shift around a little bit. Here you can see then the collaborations that we have, that we are being reached out by, or that we are reaching out to, working more frequently together, or that we have interactions with as needed. So it is quite all over the spectrum at this point in time. And that's one of the parts that we look at. And in all that is that we need to make a distinction of the EHRA being at a more policy direction, strategy level, less so on the actual, or not so at times, of the definition of, let's say, specific standards. That's where HL7, that's where the networks, that's where other initiatives are focused on that. But this is a great place to get an audience, a sounding board, a perspective from those that focus on EHRs and related HIT around that. So with that backdrop a little bit, wanted to have and open the conversation with a couple of different slides, not many, but where we are going to go into that. So jumping out is that, what are some of the challenges? And we're going to go back and forth between Michael, David, myself on this to jump into this. But when we look at it, is that we're particularly looking at considerations around the variety across jurisdiction, the variety across patients, the provisions that are around information blocking, and then some of the formats that then are being made available or are available today, which where we're really looking at non-standard, narrative, non-computable policies and directives that we need to try to figure out how can we move forward. And I'll jump to Michael to provide a little bit more color and depth behind that as well.
Yeah, sure. So a lot of where we are collectively encountering challenges as health IT developers in supporting healthcare organizations is that our products are, sort of designed for broad use by organizations that, of course, serve patients across many different jurisdictions. And so one of the things that we spend a lot of time sort of thinking about is with the fragmentation and lack of consensus at sort of a policy level about, the degree of granularity that of privacy controls that patients should have over their health information, and whether that should vary in different contexts is, really challenging for us as health IT developers to then turn around and incorporate, those sorts of granular controls into our systems, because there isn't consistency in how those expectations need to be met across jurisdictions, especially given that, even within a single healthcare organization, they may practice across state lines or jurisdiction lines that have very different privacy expectations and expectations of the level of control that patients have over their health information. So that obviously makes it really challenging for us to standardize, the tools that healthcare providers and patients have available to them to, accommodate the different degrees to which they wish to have control over their health information, especially when there's different state laws that may, conflict with each other that we have to design our products to, support compliance with. And that sort of leads to, kind of a fundamental tension between, giving privacy controls. And one of our other big goals in the health IT space and the healthcare space in general of promoting interoperability and enabling better flow and exchange of health information to improve patient care, right? So there's sort of rightly a lot of frustration when as a provider, it may be challenging to get a complete set of records across all of the locations where a patient may have been seen. But a lot of times what we're finding more and more these days is that it's not from a lack of technical capabilities. And in fact, we've seen a lot of advancements over the last several years in the standards that support interoperable information exchange across different health IT systems. But what we're seeing more and more is that a lot of organizations are struggling with consent and privacy expectations and how they can trust that when they are, exchanging information or patient records with another healthcare organization, that they are doing so in a way that is compliant with their state's expectations. So there's kind of a tension there of how do we continue to, advance interoperability and advance information exchange to improve patient care, while also respecting, the very real desire and right in many cases for patients to have control over their health information and have informed consent over where their information is flowing. And ultimately, what I think we sort of see as the outcome of all of this is a need for the ability to standardize privacy and consent rules into machine readable rules, or translate them into machine readable implementation specifications that can be incorporated into information exchange workflows and health IT systems, so that the right policies and controls can be applied when information is being exchanged. But then that, of course, leads to all sorts of downstream challenges of who is making sure that those rules are being applied correctly. And a lot of times that can require manual intervention and isn't always sort of determinable by a computer of when a privacy rule should apply versus when it shouldn't, based on context-specific information. So there's a lot of challenges that we're working through, and I think that as health IT developers, we're excited to work with any groups as they sort of look at how we can start to break down some of those barriers to enabling better controls and granularity over the flow of health information, so that patients do feel like they have meaningful control over how their information flows.
And maybe to then add to that from David, your perspective, maybe some thoughts on while we have a lot of data sharing that falls in the category, it's okay to share, and we don't need to necessarily at the level of granularity to provide those controls on the data. Behavioral health is an area that, as a result, data is just not being shared, even though it would benefit greatly from being shared more than what we have.
Yeah, thanks, Anj. Behavioral health providers who see people very frequently, are deeply involved in people's lives, have, for example, really detailed social determinant of health information on just about everyone. And unfortunate because many of the rules and privacy problems that we face right now in behavioral health about sharing information, they revolve around 42 CFR Part 2 or local jurisdictions, which are understandably trying to control that flow of data. Many of these laws that are in place in behavioral health, for example, were written even before we started to have electronic information exchange, where we were able to start to break the data into what should be shareable, what shouldn't be shareable. Many of these were written for a paper chart where people didn't have that ability to break data out to be shared. And so even though a lot of that data is there, and behavioral health providers are starting to get the capability to have a two-way street with interoperability, most do at this point, that data is rarely being shared. sometimes it's being shared with regional health information networks. Sometimes it's not, but it's really this big piece of data that sits there that could really be beneficial to primary care if they had that information in. It could reduce the burden of collecting data oftentimes. It could really help with having continuous updated data and not having to constantly be wondering if that person is still having these kinds of social determinant of health inequities. And so that field has really been struggling with the privacy and consent directives that come out of various jurisdictions.
So with that is that looking at those challenges and particularly then how do we get that in with EHRs, HIT in a computable fashion to minimize burden on both the source on how to address what can be shared, what cannot be shared, that we can support that in as automated fashion as possible in accordance with those policies and directives. That's where the challenge lies, and where we're looking in our discussions around two basic approaches, where most of the work in a way, if you look at certified software, seems to have been looking at one of them, where at this point in time, some of the efforts that are going on in the industry are looking at the second part more, that provides a lot of promise. But there's a lot of work to be done, that some of the assumptions that today at times we have these data segmentation standards, why don't we just tag the data, that they are not necessarily going to address what's necessary. And just to give that perspective on where we generally see the challenges, is to distinguish between those two approaches. One is to say is that tag the data at the source with a set of agreed to flags, and there's still a fair amount of work to be done to get those policies encoded in a fashion that they are universally understood. Not just the variety of privacy policies across jurisdictions and organizations, but also the patient consent directives, that they can be recognized as well. Otherwise, it will always require an individual to assess whether data can be shared. And that's what we're trying to minimize, if not eliminate, wherever possible. But if you do it with just a tagging by the source approach, then the data is being tagged at that point in time. Data, documents, transactions, you pass it on, it may act on it and pass it further along, but it is hard to then change the policies and directives on data already shared. If tomorrow policies change, if tomorrow my directives are adjusted in whatever direction, I would have to start to chase this this set of data that's being shared all over the place. It is a substantial amount of data that, as it's being expanded across the pipelines across the national networks, it's amazing how much is being shared and reshared, and trying to chase that down is just going to be hard. So on one hand, it sounds like a fairly straightforward approach, just tag it and then goes along, but then being able to keep up with it and then move it along and understand it, that's hard. So some of the approaches that are starting to be explored, which we are really in a way excited about on how they evolve, but we need to learn more about that as well altogether, is these centralized consent repositories. And some of the examples that Stewards of Change, ONC Leap, others are working on have more characteristics of that, where we have a patient being able in a central, for them, a central repository, collect their consent directives and have defined policies in a common, consistent way, that effectively every time data is being shared, it's either asked for or it's being pushed, is that there's the opportunity to assess the current state of what the policies are, and whether in that context data can or cannot be given or pushed or responded to the next party. That shows a lot of promise, but there's still a fair amount of work to be done. So our concerns are predominantly around how can we advance this. There are initiatives that are going on across different states different areas that are all looking at it in their specific area, but to make it scale at a national level, at least, that's where we believe that there's a fair amount of work to be done to build into that and to progress to that, so that this large volume can go there. So I'm going to go back to Michael with some additional thoughts from his perspective on this.
Yeah, no, I think this really just highlights the fact that, in the context of, determining how to operationalize expectations to collect patient consent and when it is appropriate to share what data, getting into the details matters, right? Because, what one individual might consider sensitive medical information related to a particular diagnosis or medication that they're taking, another patient might not consider that information as sensitive and might be more willing to have the same diagnosis or the same medication information shared across, the set of providers that is caring for them. And that problem becomes, kind of compounded when those decisions are made at the state or federal policymaking level, where there might be regulations that define, certain conditions as, introducing heightened privacy expectations on how that data is treated. And that can be really hard to translate into, how that information is able to flow and in what context it can flow. So I think that's where we see some of the promise of, the centralized repository, in that it really sort of moves some of the decision making about, what is appropriate to share, and requires everyone to get into the details on, like, if I'm exchanging data with another healthcare provider, is it okay to share that diagnosis code or that information with that other healthcare provider, versus are the rules different if I'm sharing that information with, say, an insurer, or with a public health agency, or with, a school district, in the case of, a child that is going to school and maybe wants to share certain aspects of the health record, maybe immunization records with, the schools. In what context is it okay to share certain information, versus in what context would it not be appropriate? And I think one of the advantages potentially of like having a centralized repository is that those rules can be defined centrally and then checked before the information is exchanged, without having to proactively set the expectation that a provider or a patient would go through and take individual data elements within their patient record.
Right, and this then allows us to base more on characteristics of the data rather than tags of data. Not to say that tags will totally disappear necessarily, but that it can be done based on another set of characteristics that's already there, and that makes it easier, we believe, to maintain the ability to adjust to changes in policies as well. So generally,
Hans, we had a question.
Sorry,
Michael, there was a question there. I don't know if you wanted to take it.
Yeah, no, I think both of the questions are sort of related to each other in terms of defined by whom, right? When is it appropriate? Who is defining what data set is appropriate to exchange? And I think that's sort of the $1 million question, right? Because there's some aspect of this that is policymaking, and there's some aspect of it that is, what is going to be best for patient care. But I think the key to both of those things is that it's really hard for health IT developers to answer those policy level questions, right? So I think there needs to be consensus within the provider and the policymaker community about, in what situations is it appropriate to exchange certain information versus and what is the scope of the information that should be shared, so that we as health IT developers can work with policymakers and providers to turn those into technical specifications and implement it in practice.
right, and related to that question is that that's where some of the challenges are on how can we make that expressive in a computable fashion. so that then the patient, in whatever repository they prefer their consent directions to be held. For the privacy policy, it's probably a little bit easier that across all the jurisdiction, we can find a way that there's a more central place to maintain that knowledge. It's kind of along the lines of what happens with case reporting and the knowledge on who is supposed to get what. There are ways to do that, but how can we do that for the patient's consent? Because they have much more flexibility to decide what to share, what not to share, with whom to share, when not to, etc. That's much harder. But unless we can do that, certain data will be with quote unquote withheld because it's difficult to determine whether it can be shared, and therefore people will err on the side of not sharing rather than sharing, and that's what we're trying to need to try to get around.
Yeah, and there is concern as well on, Michael, you touched this a little bit, but on the receiver of this data, and who there's sometimes a reluctance on sharing to agencies that may not fall under a certification, for example, like social service agencies. And is this data being protected by privacy in the same way that we protect, meaning the healthcare provider is protecting that information?
Yeah, and there's a question from Matt about responses from EHR vendors on running it through centralized consent repositories. I think that's part of the learning right now, is that on the one hand is that it sounds much easier in a way to tag the data and let it fly, but that has an effort on the side of the source to do that. But from a system perspective is that I need to touch it once. At the same point in time, every time, quote unquote, that I am being asked or that I'm going to push information that I need to consult with a central repository, sounds like that's very interactive, etc. There are likely technical ways that we can deal with that, because and this is what we need to learn. So we'll now hear a little bit of crystal ball gazing, perhaps in some areas, but that's part of these conversations that we can work through all that. Is that from a patient perspective, as they register they are with their provider, it's known to that provider who that patient is, and it therefore can be known what where the patient has the preferred central store as that evolves. Maybe right now it might be at the state level because the state wants that. Over time, that would be my choice as to where I want to put that. At that point in time, the providers that I have chosen to be with, they have the ability to get quote unquote cached, current, reasonably quickly updated versions of that, because I'm entrusted with their care. So I have the ability to at least get what relates to me, the data that I have, the rules around that. So it's a little bit of an interaction that I can refresh and keep that up to date in that sense. So yes, it sounds like it imposes more interactions. On the same point in time, it can help benefit downstream. And what's that balance? That's what we need to learn. It's interesting to see that various states are going that route, or that ONC LEAP project in San Diego is exploring that kind of an approach. That's also where you see in the UK, you see in Germany, in other places, you see that kind of a model evolving further. It has substantial promises on being able to have a better picture, holistic picture of what the patient wants, and not scattered all over the place without the ability to take advantage of that.
And most of those settings as well, Hans, have a patient ID structure that is universal to their system.
Right. So challenges around that. So last slide, just to recap, and then I think where perhaps conversation with the EHRA across a number of vendors, where other activities need to occur with individual members of EHRA. But it's really then, in order to scale this, these are some of the key questions that we will be looking at, that where and how can we address them? Because today, if you look at the right-hand side, and we say, sure, we can use DS4P data tagging of documents, and we can do security labeling on FHIR, and you can use the ARV on version 2 messages, the main areas where this kind of data would be communicated by. But that's still that first approach, and that has its challenges. It's not built out. We don't have sufficiently to have all the policies agreed to and computable and coded. that we understand what they are. We don't have patient consents in a fashion that can be evaluated without a human being. So those are these questions are the main ones that I think we're all struggling with, and how can we make progress in that area? So without that, all these other pieces are individual local opportunities, perhaps, but not scalable if we're going to share data through care quality, TEF, HIEs, et cetera, at large scale as fast as we can. So want to see whether Michael or David have any additional comments before we only have a couple minutes left.
No, Courtney brought up a question and the answer is yes, there are states that have requirements for some social service consent activities. Not all. And part of the issue, and I don't know if folks remember, when PDMP came out to address the opioid crisis, there were 50 different standards that were put in place. Every state had their own standard, which made, the benefit of the product, the benefit of that information less than it could have been. So,
yeah,
Michael.
Yep.
Yeah, no, I think you all hit the nail on the head with your comments here. So.
Yeah, and Brian, you made a comment about as you put more into central repository from a patient perspective, that they can identify which one is their favorite repository. It still means is that there is a central place where you have to protect it against gating insights as well. So that's part of the balancing act. Yes, I can have it fully distributed and I can isolate that, but does that allow me to as data changes, as policies change, as things move around, to have the insight from a patient perspective, what their desires are. And as privacy rules change at jurisdictional levels, how now I need to start to be able to manage that. So absolutely part of that balancing act to make sure that that's all protected.
And I'm not objecting to centralized consent service utilities. That's what we've been architecting here within UNIFY, albeit balancing that with data segmentation for privacy and, of course, the fact that the end systems themselves are still going to hold the information, and we're not likely to get them to give up responsibility for managing consent and authorization within their own servers. So there is a balancing act to be found here, and yet some value as well.
Yeah, and that points to is that there's still a lot to be learned and to be done before we have a good fabric around that that can make it work not only locally or in a small set of interactions, but that we can reliably use and know that as the data is being shared, that they're being managed according to the right policies and directives at a national level. And I think that's where we're looking at to say that where we're at is still a ways to go to get to that level. And the expectation that we have to be careful about that what is being asked for in certified software today with data segmentation, that solves the problem. No, it does not. No. Still a lot more to be done to make it happen. And our members are very interested in that, but it's also very hard not to crack. It's not.
I haven't done the original DS4P working group. I'm a fan, but it's not a be-all and end-all solution to the problem. It solves a very specific, a very narrow, specific set of problems. Right. We need to deal with it.
So we gotta wrap things up here, gentlemen. Run over, but I think it was really helpful to be reminded of the challenges that remain inside of medicine itself, and that these, as we solve these problems inside of medicine, that we can reuse these solutions to do the broader sort of data sharing and connectivity that most of us on this call are interested in, but that we need to really work hand in hand with those of you who are really trying to architect this first within medicine. So I really appreciate the three of you joining us today, and really sort of highlighting for us how much work there still is to do, and how we need to work together to solve the specially protected health information questions, and then we can extend those solutions outside of medicine as well. It's really, really helpful.
I'll just say thanks again for making time, yet again, more time to talk with us, and of course, raise more questions and more interest in further conversations. So I'm hoping as our work goes forward and we talk more with HIMSS about the upcoming event and with Amit and everybody else around, maybe being able to sort of have a conceptual demo of this, or a conversation at least, would be great. And then the proof of concept sites that we're hoping to launch sometime next year would bring you into that, and because they're all the EHR vendors are part of it, and sort of solutioning there would be great. Last thought is next week, Evelyn Galego will be coming back to have a open conversation, and we'll extend it to the full 5:30 at that time. We can bring back part of this conversation. I'd love to be able to bring it back relative to the gravity codes and what that whole transition with Civitas and all that stuff is going to happen. So if you guys can find a way to come back, that'd be great. And we'll record it, we'll put it out there, and it sounds like this will be a great part of a next conversation, or several next conversations over the next period of time. So with that, everybody, we'll record it, put it up on the hub. You can find more information there as well. You should get a message there. Have a lovely rest of the afternoon.
Thank you.
Daniel, very
Thank
quick
you all.
one.
Thank you
Just
for your
pick-
time.
Daniel, could you very quickly just pick a date in November on a wedding